I first want to say thank you, everyone, for inviting us to talk. Incredibly honored and privileged to have the chance to talk with you all and kind of share experiences and share some of our research. This is one of the reasons we do it. Hopefully, usually trying to tie things back to how people and patients live. And so, as we mentioned, I'm Dr. John Hunting. I'll introduce myself in a moment. Dr. Sarah Price is a collaborator and friend. And so we did a study on survival impacts of immune-related adverse events in extensive stage small cell lung cancer. Just a brief overview of the way we'll walk through this. I'll do an introduction because I think it's important to you to get to know me as we talk through this, some background in my thought process, our thought process for why we did this study, the study itself, where we think this goes, and then we'll chat about any questions that come up in the meantime. My name is Dr. John Hunting. Professionally, I am from North Carolina. I did my undergrad at NC State. I did a master's in public health at Emory, where I studied biostatistics and epidemiology, and then worked as a biostatistician back here at Duke. My parents, both Tar Heels, both undergrad and law school, were very disappointed, but they learned to accept it. And they went and did my med school up at Georgetown in DC, where I had a great time. And I just finished my residency for internal medicine here at Wake Forest, where I stayed on as chief resident. This year, I'll be going an oncology fellowship next year. Personally, as I mentioned, I grew up in North Carolina. My family actually lives in Brevard, and if you have not been, I cannot recommend it enough. It is an absolutely delightful little mountain town, about 45 minutes south of Asheville. It is lovely, bustling mountain town. Other things, I actually began, little fun fact to break the ice, I began rock climbing about 4 years ago. That's actually how Dr. Price and I are friends. We climb together multiple times in the week. I actually picked it up to overcome a fear of heights, which I've gotten better with. It's still there, but we're getting there. The thought process leading into this study. So extensive stage small cell lung cancer, which was kind of the focus of this study. There are really two kind of groupings for oncologists, and they start to think about small cell, limited stage and extensive stage. And the reason for that being is it's a little bit different than stages you hear for cancer a lot of the times. 1, 2, 3, 4, kind of how people understand the severity or extent of a cancer. Small cell is different. It's special, given that it's usually one of the more aggressive ones. And so we kind of broke it into two categories: limited stage and extensive stage. And extensive stage being really when it's kind of escaped its home, its origin. So if it's gotten outside the lungs and the thoracic cavity, we usually call that extensive stage. It's really difficult to treat because if it's now gotten its way outside of one home, focused things like surgery, necessarily radiation, well, they're not going to be able to focus on that one spot if it's moved to a couple of different ones. So the trouble with small cells, it likes to work its way through lots of different spots. It loves hematogenous spread is the word we use, that it loves to move through the blood, which the blood goes all across the body. So that's why our backbones, our main treatments are usually whole body treatments, things like chemotherapy, immunotherapy, systemic treatments. So immunotherapy, as I mentioned, it's this new emerging kind of treatment. If old chemo, its dogma essentially was cancer grows fast. Chemo is drugs that attack fast growing things, and so hopefully hurts the chemo more than it hurts us. And that's why chemotherapy historically is a tough drug. It's complicated. And immunotherapy is kind of the new age of a new school of thought. So if we all have cells throughout our body and they grow and sometimes they get abnormal, they do various different things, our body actually has built-in checkpoints or ways to regulate that, take care of it. That's our immune system. We all actually have cancer probably at some point in our body at any point in time. One cell that's gone rogue, but our body has ways to deal with it. And then cancer, in its formal way we understand it is when it's gotten past that, it's progressed. And one of the ways it can do that is it can pretend to be a normal cell. So that's through the PD-1 markers. And it's a way that cancer cells can hold up a little flag to immune cells and say, I belong here, you should let me stay. And it kind of hides that way. So some brilliant researchers once upon a time said, well, what if we take care of that flag, take it out of the cancer's hands? And that was kind of the birth of immunotherapy. So these drugs, as it says here, like to target the mechanisms that was masking itself, typically through PD-1 or PD-L1, which is kind of the flag and the grasper, essentially, of the mechanisms. Two of the drugs that are commonly out there for extensive stage small cell are atezolizumab and durvalumab. They are mouthfuls. You are not alone in saying it's a lot of words, and a lot of my med students have trouble working through those. But it's an IV medicine. We usually give it every 3 to 6 weeks. Depends on the study, but most of them have shown pretty similar times between them. So usually we say if it's similar, we can space it out to 6 weeks and make people's lives easier. If it's easier to come in every 6 weeks than it is every 3, but they're both usually options for different infusions. So an analogy, in full disclosure, I did ask for some feedback from ChatGPT to help me with thought process and just kind of tying it all home for immune therapy. But I think it did a pretty good job. That if the immune system's like a guard dog and the PD-L1's the leash kind of saying, no, it's fine, hold back. If the immune therapy kind of clips that leash, it releases the immune cell to go do its job towards the cancer. Now, kind of incorporating all that, you may have heard the letters NCCN guidelines, but this is the dogma, the schema that all oncologists kind of live by. It's the official guideline, that's the expert recommendations. And for extensive stage small cell lung cancer, the standard treatment or the first line is chemotherapy with immunotherapy. So again, it's a little different than if it was limited stage, which has various different treatments or options or paths. But for extensive stage, when you say we're worried for the whole body, we have whole body treatments. It's worth noting that though every patient and every situation is different, and so all the things that are important to you, things that are important to the oncologist, it's always a discussion. It's always kind of a balance. So I note here that performance status or how we feel or how sick we are may influence the treatments that are best for us. So why immunotherapy with chemotherapy? Well, it kind of works again through those mechanisms that's different than traditional chemo that we talked about. And it's been shown actually to have benefits. So there are a couple landmark trials we reference. One of them is called Caspian. It's funny, the group that does these studies names all their studies off of seas. So they helps to remember all of them. So the Caspian study is one of the main ones that first showed immunotherapy having a survival benefit by at least several months for patients who got it in just chemotherapy alone. But it's important to note that no drug is perfect and everything has a risk and benefit discussion. And so immune therapy, given it's a different special kind of medicine, has a different and special kind of side effect and risk that we should talk about. And we call those irAEs. And so what are they? Well, in a sense, if the treatment unleashes the immune system and that regulates inflammation, we think back to getting a cold and the ramp up of the white blood cells and how we feel feverish and things like that. Well, it's the exact similar process of ramp up the inflammation in the immune cells. Well, it can cause inflammation. And because it's a systemic treatment, it can inflame anything in the body. Common ones are the thyroid, skin rashes, diarrhea, lung inflammation, liver inflammation, but truthfully, it can happen to anything. We also broke it down because we love to characterize, to better understand their different severities. There's actually 4 different levels of the side effect, but for the most part, we break it into low and high. If a low grade side effect is something that's frustrating or annoying, but it's okay with a little bit of monitoring, maybe a touch of steroids, it'll resolve. And then a high grade is something that you have to go to the hospital for. It's something if you have trouble breathing or chest pain or things that actually need to be seen, admitted to the hospital and given some good steroids and keep an eye out for you. It's tough because timing. So if I had a way of saying and predicting when and how something would occur, you bet I would be planning far ahead and making all the right adjustments. But it's tricky because the timing for irAEs, though they usually happen early, can really happen at any point in time during the treatment or even after the treatment. The diagnosis is tough because there's not a magic test I can do. So usually I need to go by the symptoms and then rule out everything else that it could be. And then once we're left with making sure it's not anything else, this is what we're left with. Usually that means ruling out infections because the treatment is steroids and making sure that there's no infection hiding that would get worse by steroids is always very, very important because first do no harm. And so kind of with those couple of points, I hope that shows how difficult a side effect or a presentation or a concern this could be if it's inflammation anywhere in the body at any point in time of varying severities and doesn't have a magic test. Well, that makes it quite difficult to really treat. And so that's why we started asking more questions about how, when are they occurring, and then what does it mean for our patients? And so that's what leads us to this study. The question was, so there have been previous studies, especially in non-small cell lung cancer, of which immunotherapy is commonly used. They've actually shown a survival improvement with patients that have these events. Well, that seems strange. If we're causing additional harms and risks and things like that, well, why would someone do better? Well, I think it goes back to the original thought of, well, what are these things doing? If we're attacking the cancer with immune systems and inflammation, might more inflammation actually be a good thing in some respects? Could it be a reflection on increased activity or killing of the cancer? Could it just be a stronger immune system? Great questions that we don't have the answer to, but are great questions for further study. But my question came up, well, we've shown that there's this benefit in non-small cell lung cancer, but small cell is a different beast in itself. So is that still true for this group? In Winston-Salem, of which I am located, we have Winston-Salem being the two well-known tobacco sources. It's actually a really prevalent disease for our population. We had 245 extensive stage small cell lung cancer patients in our cohort, and that's actually very common for this rare disease. And so among these patients who got immunotherapy, 23% of them had irAEs of any grade, and 42% were a high grade, which means they had to be admitted, which is fairly high. A normal rate for high grade events in non-small cell is closer to 20% or so. So this was fairly high. Tough to say is that a reflection of these patients being a bit sicker in general because they're all extensive stage small cell? Very possible. And so for most studies, we usually look at, well, who are they to better understand all the details behind them? Because you always want to make sure that there's nothing else explaining our findings kind of behind the scenes. So we look at who are they, and kind of the things about them, and we compare them. So age, sex, race, BMI, ECOG stands for one of the performance statuses, 1 through 4, and then smoking status, all of which you see the p-values up there are large, which means they were not statistically significant between the groups, which means none of these variables that we were making sure were different between the high grade or the low grade events. So all the patients that had these events or didn't have these events, they were pretty similar, which helps me kind of take all those other explanations off the table. So what about the outcomes? Well, the two main things you mentioned we were interested in were survival. So overall survival is one of the key metrics for most oncology studies. And progression-free survival is the other one. So as we follow people on treatment, we check in with them. We check scans and see, are things growing? Are they shrinking? And as long as things are stable or getting smaller, that's a positive response. And if it starts growing again, well, that's when we've exited the progression-free era. So these patients, we found a really interesting finding as well. Very similarly mirrored the non-small cell lung cancer group. We actually saw a survival benefit. And it was actually quite significant in my mind that these patients, especially with the low-grade irAEs, had almost a double improvement in their survival. So you see there the hazard ratio. It's a statistical term for kind of the risk at a point of time. If one is, both groups are the same, so it's a ratio. So one is perfectly balanced, no difference one way or the other. Greater than one being more risk, less than one being less risk. You see right here for overall survival being 0.38, that's a very low number, far away from one, showing these patients had a much lower risk of death, of passing, if they had this low-grade event. You see over here for the high-grade events, it's 0.69. The statistical numbers and terms over here, it goes from 0.42 to 1.4, and in between those two things is 1, which means in statistical terms, I can't tell a difference. I can't prove it. I can't be 100% certain. So we're going to say no difference. So what that leads us to think is, okay, that difference might be most pronounced or easily found among the low-grade events, and we can't say one way or another for the high-grade events. If you're a picture person like me, like this helps with that. And so these three lines are our patients with no events, low-grade events being the red line, and blue being the high-grade events. And you see the lowest level is the green line, patients without any adverse events, and they kind of had the lowest line, so the most risk of death. But our patients with the red line, who had low-grade adverse events, at the highest. And then the blue is somewhere in the middle, a little close to the green. But I think that just kind of is another way to reinforce, or kind of, for me, as a picture person, show that there was a really big difference between these patients. We note here, so the numbers are tough because you remember we had only 240 patients, and among them only about 40% had those higher grade events. So it's getting more and more rare. And so as you have less and less people, it's harder to show a difference. Also, when you have a high grade event and you're hospitalized, usually that means we say the risk of immunotherapy is too high, and it's no longer worth the benefit. If it caused you to be hospitalized, it's a risk. And so we usually say we can't do that treatment anymore. But for low-grade events, it's still an option, and you can discuss with your oncologist and talk about what's best for you and find that balance. So it's still an option, and that could be another option or explanation for these results. So as we reflect on kind of the meanings behind this study, I think it's where it goes from here. Immunotherapy is shown to be beneficial in small cell lung cancer. It's an extensive stage. That was the Caspian study that said this helps people at baseline than not. It is better to have this than not. But as we mentioned, every medication has risks and benefits. And immunotherapy is paradoxical or special in the fact that, well, it's a risk, still might even have some more benefit. But it's always important to balance those risks and have discussions with your oncologist every step of the way about what is best for you. I put here just food for thought. This is an advanced statistical term. You can take it or leave it. But immortal time bias, for those that are curious, is a question of, well, if I wait for an event and then see beyond that, am I just seeing this earlier part of this first event? Possible. Very great question. In this situation, I think that the benefits, so if we say that your events had the risks and the irAEs happen the first 1 to 3 months, but our time was over doubled, well, that math doesn't necessarily math up and says there's even more benefit, but it's an important consideration as we reflect on this study. So where does it go from here? Well, we still need to work better on detecting the events when they happen. I mentioned they can happen at any time, in any organ, in any severity. So it's important to talk about them and be aware, because it's ultimately the patients I rely on who bring them up to me and tell me what they're feeling, and we can put it on our radar and start working through our test early. The mechanism of these events is still a great question of if it has survival benefit too. Is there a way to get the benefit without the risk? Another great future study. And then again, just figuring out better ways of figuring who and when these events happen so we can find them earlier. And then I also just put here a future thought or a plug for all this. There, Aspire is a research working group I work with. It's multi-institutional. There are people from Boston and California and all over the country, and we partnered with to do some research. They are a very active and fun group. Unfortunately, I'm not in this picture. I was, I think, in a lecture on the back right, back in that hall during this time. But there are so many passionate people in oncology. This group is made up of oncologists, rheumatologists, and primary care doctors, just all focused on these special events themselves. Huge thank you to all my colleagues, Dr. Price, and everyone else who is involved in this study. Truly is a team sport, and I'm grateful to have them as colleagues. And I guess now I wanted to probably take a pause to check in with everyone about any questions that had come up and go from there.
Sure. Yep. I have a question. Then I see one just came in the chat. So that sounds like some of these are self-reported, like symptoms. So 245, that is a good number. So did that cohort just come together, or did you collect as soon as the diagnosis came, or when they presented as having a symptom?
Absolutely. So this is a retrospective cohort. So we actually have a database here that we built for all immunotherapy patients we had for about a 5-year period of time. And the diagnosis is made from patients and the queries. And so it's also kind of recorded in EMR. And we had a group of chart reviewers that helped us out as well, that reviewed everything of calls and logs and oncologist notes. And so at the base, the diagnosis usually comes from a patient making sure to tell their oncologist whatever they're feeling, whether it's a rash, chest pain, trouble breathing, diarrhea, and then the oncologist working from there, and who ultimately says, I think this is an immune-related adverse event, and they will code it as such.
Okay. Then we have a questions, at least 2 right now in the chat. The first one is, what are the most common AEs, and define the severity? If you had I think it's irAE, on one immunotherapy, would you also have it on another?
Great question. So we'll go back here as far as how common are they. So in this cohort, about a quarter of our patients had any kind of event. And among that quarter, for about 42% were high grade. So among everybody, probably 10% had a high grade event. So not common, but not uncommon. It can happen. And small cell, usually some of the more common ones for our patients are thyroid. So they can get either the thyroid goes too high, too low. It has its own effects we would detect. Diarrhea is a common one from colitis. So the colon itself gets inflamed, and that leads to diarrhea, or inflammation of the lungs. And we can usually tell by shortness of breath. Kind of the severity of those things being, how do I need to be admitted? So if you have diarrhea that's so bad to the point that you're dehydrated, that would be a high grade event. And if you have trouble breathing where you need some help in oxygen, that would be a high grade event. And that's how we break those down in the different types.
Okay. And the second part of that question, if you had, it's going to be similar to the next one, but if you had an AE on one immunotherapy, would you also have it on another?
Also a great question, and not necessarily heavily studied, but that's a question usually you would bring up with your oncologist. It would probably have the risk, and that's why we usually say for patients who have high-grade events, well, they probably are of too high risk to try another immunotherapy, and we usually focus on other kinds of treatments. But that's why for those low-grade events, you can have the discussion of, well, do we want to try something? We kind of talk about what the effects were we experienced and you experienced, and then kind of have that option. And sometimes it is an option to try a different one. And some people, then you straight confers its own risk, and they're probably at a little bit higher. I don't have the data on hand, but definitely would be an option for discussion for those low grade events.
Thank you. Next question. Is it true that if one immunotherapy didn't work, that no immunotherapy will work? My husband's doctor would not try a second therapy.
Usually they work through the same mechanism. So if they're targeting the same problems, if that's there we go, the PDL1 spot, that flag, it's the same flag, but the drugs just are a little bit different in their approach, but they still approach the same flag. And so we don't have any data to show that they would respond differently. And so usually the school of thought is that it usually wouldn't have a response, because not every cancer would respond to this treatment. Not every cancer uses this flag or uses it entirely. They all have their own sneaky ways of hiding from our body or fighting their fight. And so it is probably unlikely that another different immunotherapy would work differently if they're still targeting these same spots, unfortunately.
Thank you. The next question is immunotherapy ever used in limited small cell lung cancer to prevent it from becoming extensive?
Great question. I think that's a current area of study, actually, to see if it integrates into the NCCN guidelines. And usually the way these things work is they include it in a lower line of therapy, so kind of down, and then it works its way up and needs to show one step at a time, okay, I have some benefit. Am I better than the next one? Am I better than the next one? And then it works its way up to the first line. But I believe there is some current work to include it into the limited stage small cell. I think there are some indications for it.
Mm-hmm. Thank you. And what is the effect of chemotherapy on immunotherapy and adverse events? Doesn't it have an immunosuppressive effect?
Another great question. So yes, in ways. So in chemotherapy, in the many different kinds that it is, so if its ethos is to attack things that move too fast, some of those things are us, but most of them are the bad cancer that's growing too fast. Well, then it does impact people's immune systems. It works differently. So sometimes it hits the blood marrow, and that's why we have low blood counts, which some patients have with their various chemotherapies, whether it's their platelets, their red blood cells, white blood cells, a common side effect of the chemo. But it doesn't necessarily work through this mechanism of how they're activating. So it kind of works in two different ways, but not necessarily blocking each other, if that makes sense, for the immunosuppression part. And as far as the adverse events, they're also different. So it's hitting things that move too quickly. Well, that has its own way of causing side effects. The hallmark or the classic, one of the side effects being hair loss. Well, hair grows really quick, and that's one of their key reasons why that it would attack the hair, or causing diarrhea as its own different mechanism for hurting the colon cells. So in a sense, they have different buckets of adverse events that happen in different ways, and it's entirely possible they could both happen. But they are both working through their own ways in that same regard, cause their own benefit. That's why the Caspian study showed that it was beneficial with it and showed people lived longer.
Good. Thank you. And so now, still talking about immunotherapy, but so tarlatamab is targeting DLL3, so that would be different, correct?
Yes, that would be a different. There are currently, the PDL system was kind of the first hallmark for immunotherapy, and there are currently maybe another half dozen different targets that are currently being worked on, explored, whether it's through current trials or in labs. So it's definitely an expanding region of multiple different targets, which could be kind of going back to the prior question of, well, if it didn't work, could I try a different one? Well, if we had different targets, then that could definitely be a question to discuss. So yes, different target.
Okay. Generally, how long can an immunotherapy continue to keep cancer at bay when you have an initial great response but have to discontinue due to bad side effects? Tarlatamab specifically.
I'm not familiar with tarlatamab myself. As far as immunotherapy in general, though, there have been some suggestions that the effect is actually quite prolonged, that patients can show benefit for many more months, if not a year, and kind of it's a prolonged benefit even after your last dose. And some patients who even don't have an adverse event go on to more maintenance therapy and can stay on the drug. And if you've gone a long period of time without the adverse event, many patients can stay on for maintenance dosing. For question of how long is it still beneficial if it has a long effect, but some patients will stay on for 1 or 2 years even after.
Mm-hmm. And that's a good question for your study. Did anyone have to drop out of the study due to the side effects being too intense?
It was not, thankfully, it's not a prospective study. So I was just looking at kind of how they went through the normal course of their treatment. So no one had to drop out, but they, many patients that had those high grade events had to stop their immunotherapy.
Hey, adding immunotherapy to limited stage, and that did just recently get approved. It was part of the Adriatic study, and now that is the standard course of treatment if you are limited stage. Once you complete your chemoradiation, then you would go on to durvalumab.
And I thought last month, Lynn, I think there were some studies in there too that probably took a few, maybe that talked about limited stage. So, yeah. I know the initial focus on research has been extensive stage, so I'm glad to see some unlimited. Very good. Well, thank you so much.